Okay, so we're going to talk a little bit about now labral tears in high-performance athletes. And I don't know what your definition of a high-performance athlete, but it's not the older patient. It's usually a worker, an athlete, could be high school, could be college, could be professional, somebody who doesn't want to have another surgery. I don't have any conflicts of interest with this presentation. So we know that the anterior labrum tears, and that's the most common thing we see with anterior dislocation. And the contact hyperextension type injury is usually something that can cause an anterior labral tear. And this is one of our quarterbacks, football quarterback, who subluxed their shoulder with this activity. And we all know the Bankart lesion is the most common lesion with anterior instability. Anterior labral tears in throwers are different. Many times they have an anterior inferior labrum, just a little bit labrum detachment. It may not be as big as you see in someone who dislocates their shoulder. And often they have two posterior superior labral tears, as we showed before, where you have to look not only for a tear in this area here, but something posterior superiorly. And like we talked about before, sometimes you have to repair here and repair here. Why? Because once you get a pseudolaxity, the humeral head goes posteriorly like this. It can go back and forth like that. It could be from the slap tear, can create some laxity anterior inferiorly. Pseudolaxity in the humeral head can be forced anterior inferiorly and can cause some pseudolaxity of the shoulder. So the posterior superior slap tear can cause a break in the labral ring and create translation of the shoulder. And in a position where like that, the humeral head should not sublux anterior inferiorly because it will decrease performance in the thrower, the throwing athlete. And we know that capsular laxity from doing this many, many times can be associated with anterior inferior labral tears. But again, you don't see the big Bankart lesion like you do in someone who's dislocating from contact injury, like a football player. Because repetitive type movements over and over and over again can cause a degenerative anterior inferior labral lesion with some damage to the glenoid as well. So it will look different. And when you're trying to diagnose anterior instability in an overhead athlete, many times they will complain of numbness in their ulnar nerve distribution. Their arm feels loose, and they have what's called a dead arm syndrome, where they throw and their arm kind of goes dead because they sublux their shoulder. You can pull inferiorly on the shoulder, and it reproduces the numbness in their fingers, so it shows you that there may be some hyperlaxity or micro instability of the shoulder. I work with Dr. Job in my training, so I learned the Job test, the relocation test. So they don't like when you go back in this position because you are externally rotating, you're pulling the humeral head forward, you're recreating the laxity of the shoulder, but they feel better when you push down in the shoulder. They don't complain when you externally rotate the shoulder. And that can be helpful to diagnose instability or anterior inferior labral tears. But also, as I talked about before, can be in posterior superior labral tears as well. Obviously, the MRI arthrogram will show you a Bankart lesion in most instances of anterior dislocation in a traumatic type thing. In an overhead athlete, you may not see a Bankart lesion. Many times, the MRI will tell you there's some damage to the anterior inferior glenoid cartilage, a cartilage lesion, and maybe a little bit of the labrum, but that can suggest some labrum abnormalities. So what do we do for an anterior labral lesion in these athletes? Well, not all athletes are alike. If you have a football player who is big and just wants to be able to move their arm, or a rugby player, they can have any kind of labral tear. You don't have to worry about their type of surgery. They want to have a repair that's very strong, and sometimes you will tighten the capsule a little bit more, but in an overhead athlete, they need mobility more than they do stability. It's normal. They need the looseness of the shoulder to throw. If you make it so tight, they cannot throw anymore. So instability surgery for the overhead athletes is not so good. And in an athlete, like a baseball player, maybe the labrum tear, even though you see it on the MRI, because if you get a baseball player who has played baseball since they were little, they will have some problems of the labrum. No surprise on the MRI. So don't rely on the MRI. Make sure you try some conservative treatment first. And the labrum tear is not an isolated lesion. They have problems usually the rotator cuff, the labrum, the capsule may be lax, scapular dyskinesis, some articular cartilage damage, so the labrum may not necessarily be the cause of their disability. I think the better results with labrum repair if you carefully select which athletes will benefit from surgery. I think it's more important in the kind of knots you're using or what kind of anchors you use, and you should only operate on them, overhead athletes, when they have failed conservative treatment, because it's very difficult to determine that the labrum tear is really what's causing their problem. So contact athletes, like I said, big players like that, they normally require surgery because they can go back to play, so results with surgery are better than if you try to treat them conservatively for them. Stability is more important than mobility. So if they lose a little bit of rotation, you have to do a stronger repair so they can continue playing. Their stress is much better. And sometimes even in some surgeons in the United States, for this type of patient, we do open stabilization. I don't think many young doctors know how to do that anymore, but it's still something that can be useful. If they dislocate in season, typically we will put them in a brace. If you have a basketball player during the playoffs, you have a football player, if they can go in a brace like that, they can help keep you from abducting, externally rotating the shoulder, and then surgery after the season is over. So surgery, just like any other surgery, what gives the best result? Listen to the patient, listen to the history, take a history, examine, do the diagnostic testing, but listen to the patient and examine the patient to determine what you're going to plan on doing with surgery. Make sure you have the MRI. Always have the MRI report, because the patient, again, they look at the MRI report. If they see a labrum tear and there was no labrum tear at surgery, and you don't tell them after surgery the MRI reports showed a labrum tear, but I looked and there was no labrum tear, they will not be happy. So I always look at the MRI report so I can discuss with the patient after surgery everything that the MRI showed and what I did about it during surgery. I usually have my clinic note as well, what I talked to the patient about, and of course do a timeout, a safe surgery. Make sure you're operating on the correct shoulder, mark the shoulder, things like that. I think they're standards within the world right now. So I think this preparation is more important than the type of anchors, sutures, and knots you do during surgery. I always start with examination under anesthesia, as Dr. Hunter talked about. For labral surgery, I prefer lateral decubitus, rotating the head so the patient is back about 30 degrees and leaving the head undraped so I can rotate around the front of the shoulder. Always start with a diagnostic arthroscopy, and then, do it the same way every time. So you start with the labrum, the anchor, the rotator cuff, the biceps, the rotator interval, labrum. Do it the same way every time so you don't miss anything. As far as portals, you can use the scopus posteriorly. Sometimes you put the scope anteriorly so you can look down the glenoid in this area when you're doing the labral surgery. The working portal for inserting anchors can be here, but if you need to get back low like this, you can come either posteriorly or through the subscap with the percutaneous anchor, and then pull it out of your portal to do the suture passing and repair. Many portals, make sure you have enough room in front here so you have enough room for the cannula that you're using to put the anchor and the cannula you're using to pull the sutures out. And you have to have switching sticks. You must be pretty comfortable. I teach my residents every time, just when they're learning arthroscopy, how to use the switching sticks so they look in front, back, and get fast with moving from front to the back of the shoulder. And of course, I never perform shoulder arthroscopy without switching sticks, but more importantly, electrocautery, because if you can't see, you can't fix. So identifying the labral tear, this is an overhead athlete. This is what we were talking about before, where there's a little detachment here of the labrum, and then this abnormality of the anterior inferior glenoid cartilage, and it's already trying to scar down, so you have to kind of mobilize it. But you'll see like some abnormalities right here with the glenoid as well. So you want to minimally debride the labrum, decorticate, use a shaver to decorticate the glenoid neck. Sometimes I use a microfracture to kind of make small, just to get some bleeding in that area if I don't see it bleeding very well. just along the anterior glenoid neck, of course not on the articular surface. You can use some sort of device like this, again, scraping the bone to make it, to create some healing, some scar tissue in that area. And immobilization is very bad, very important. And you can see in this patient, you can see the anterior band of the inferior glenohumeral ligament. So you probably don't need to plicate very much for this patient. Sometimes you don't see the band, so it tells you that it's stretched out, and you may have to plicate a little bit. Always look for a glenoid rim fracture. Sometimes it's not very evident on an MRI because I don't get CAT scans. And if you do see the fragment there, you're cleaning, see a fragment, don't take it out, of course. You try and incorporate that into your repair. Sometimes I'll use a little burr just at the very edge there to create, just take off a little bit of the articular cartilage so I can put my anchor right in that area. Again, spinal needle. I like to use the spinal needle to make sure I can get my anchor exactly where I want to put it, and start lateral, and sometimes I come through the subscap. And just, barely on the edge of the articular surface. You don't want to go heavily on the articular surface when you're doing the labral repair. And then passing a suture, you can use this device. There's probably 10 type of devices that you can use to repair the labrum, passing the suture through the labrum. We're a little behind, so I'm not going to talk too much. Plication, not too aggressive with overhead athletes. Pull from south to north, not from east to west. So you're kind of pulling inferior to superior, not medial to lateral, or else the patient will be very stiff. And then when you put, I know there's knotless anchors, but if you like doing knots, I think that's okay. Just make sure that the knot is away from the articular surface. Okay, so not over here, over here. Many type of anchors by observable peak, all suture. How many anchors? I don't know. I mean, I think every case is the same. You don't need four or five anchors. The patient is not going to be hanging like a monkey from the, after surgery. So I think as long as you get good solid repair, maybe 2 anchors, maybe 3, enough, but not too many. And I mentioned that there's been several published studies recently about anterior glenoid rim fractures from using anchors, where you get a fracture of the anterior glenoid rim. Okay, a couple papers here. And as I mentioned before, be careful with repair in this area because the patient will be stiff. So if I will repair here, but when I see the 3 o'clock position, I'm careful not to go above that unless I have a detachment of the labrum. Postoperatively, pendulum exercises, elevation and scapular plane, external rotation. With the arm at the side, you don't want to lose external rotation. And then rehabilitation and core strengthening, right? Because for throwing, the strength comes from the legs and the core. I don't see anybody sleeping yet. It's a little early, but so anterior labral tears are different from in contact athletes and overhead. They're 2 different animals, and surgery is not the first option in the overhead athletes. You must try conservative treatment first because many labrum tears are pretty common in overhead athletes. Debride and preserve the labrum, improve the biology by decorticating, use a spinal needle, plicate, but not too much in an overhead athlete. Keep the knots away from the surface. And I'm currently using all suture anchors. I don't know if that's a perfect anchor, but they're small. I don't use the triple loaded, anything like that, just simple single loaded anchors. But don't forget the perfect labral repair. It looks beautiful, but you did it for the patient that did not need the surgery because the patient has another problem. Will give you a bad result. Okay, if you didn't recognize the patient has impingement or had posterior superior labral tear, you only repair the anterior inferior labrum. Patient selection is very important. Thank you.
Thank you very much. Next speaker, Professor Michael Simoni, is going to talk about strategies to treat traumatic anterior shoulder instabilities.
So, well, good morning. It's an honor, it's a pleasure to be here. I thank especially Dr. Mohammed El Abnour, which I met in Munich, and Professor Adel for this very nice invitation to be here. So that's the guy who made the birthday yesterday. He turned 18 years old. Is that correct, Mohammed? Always 18. And so that's my disclosure, my conflict. So young people like to do sometime, excuse me. So remember that guy. That's a typical guy who will fall and dislocate his shoulder. So remember this guy for the next topic. The problem is known. Professor Tonini has shown us that most of those guys will have a labral tear or sometimes a bone tear. Imaging studies now are very important because we take in consideration a lot of bony defects now. In the past, when the arthroscopy began to increase, we took care about the labrum, but now we know that loss of bone is very important. So why is the recurrence rate so high, like pointed out by Rovelius? Because many of those labral tears, they don't heal. When they heal, they can heal back here in the glenoid as an Alpsa lesion, and that makes the instability appears. When we look to this picture here, we see how complex is the interaction between labrum, muscle, and ligaments. And that was a problem when you think that someone with 18 years old will have to live his life without the labrum. So that's something that we should take in consideration, because when we grew like 30 years studying, we say that all instability, all shoulder dislocation will have to be at minimum 3 episodes to be in the surgical indication, and that has changed over time. The concavity compression as described by Mark Lazarus and Madsen is very important, because when you lose this, you lose at least 50% to the concavity and an increase 80% of the chance of dislocation. When you see the picture of a glenohumeral ligament attaching in the labrum, you understand that there is not only a static function when your arm is in abduction and external rotation, as well as a loss of proprioception here. I always tell the patient is that when you detach the labrum, many patients ask us, should I go to gym? Should I make my muscle strength? Should I be strong? Then I'm not going to be necessary to do a surgery. And I say, if you don't have an anterior labrum, it's like if you have a lot of lights, but you cannot turn the lights on because it's broken the electric system. So I think that muscles is not an answer when you don't have a labrum, because you lose all your proprioception, as sometimes you have to the ACL also. So in our position, surgical treatment is best for first episode in young population and recurrence. But let's talk about athletes, how we see. I use what I call the age criteria. There's a lot of criteria. This is ISIS score, number of recurrence, old Tubbs and Ambry described by Rick Madsen in the past. But I use age, sports, and anatomy as my first point to decide which approach I will take. The way that I classify sports modality is very important for me, because in our population in Brazil, there's a lot of people who does radical sports, dangerous sports. So I like to divide in 4 categories. First, the repetitive overhead motions. Those are people who play tennis, people who swim. Then comes the contact, basketball, volleyball. Then comes the collision sports, which is different than contact sports, which is American football, rugby, most of MMA. That's very popular now, at least in Brazil, in the United States. And I like to categorize the 4 type, which is a dead risk sports, is big wave surfers, flying sports, rafting, and climbing. Those people, if they dislocate their shoulders during their activities, they can die. There's an article in the Surfer magazine in Hawaii that says, don't fear the sharks, fear your shoulders. And we know that there were some reports in Brazil that people who died after dislocating shoulder under a big wave. So I decided to include that as a category. So which kind of decision should I make in deciding, am I going to do a Bankart procedure, or am I going to do a bone block procedure, basically the Latarjet? So there are a lot of arthroscopy Bankart repairs with recurrence rate in the general population. There's like tons of articles, all of them of Alex Castanha, which is sitting there in the back. Showing that there is a range of variety about recurrence rates. And the main point is that male under 22 years old and involved in collision sport should be the candidate of a recurrence after a Bankera repair. It means a failure of the previous Bankera repair. Myself, I like to do, I use always the B chair position. I understand that the lateral decubit is easier to see, but I've been used to use the B chair position. I like to use knotless anchors. That's my own point. I also think that we should retension the the ligament, but we don't know exactly how much should we tension that. That's not very mathematical. We do by our feeling at the time. So I think there's still good chance to do a nice repair with a Bankera. But sometimes we see what I call the surprise Bankera repair. So we have everything to do a Bankera, we get in the joint, but then there is also a transverse lesion, which makes our procedure much way difficult because you're going to have to retention, and the quality of the bone is that. And when I looked this case, I said, well, maybe I should have done a Latarjet procedure. Should I trust this repair? 3 months, he will be in the field. Because soccer players in Brazil, if you tell them you're gonna be 6 months out of the sports, probably in 3 months, you're gonna turn on the TV and they're gonna be playing. Second, the labrum was thin, a transverse lesion with the detachment. He plays on a major and popular team in Brazil. Not a good team anyway, I don't like it, but it's a popular team in Brazil. And you know, as a team physician, that the media does not accept failures. So if you do repair and redislocate the shoulder, you're probably going to lose your job as a team physician in Brazil. However, he's 8 years and he's had no recurrence so far. What about professional goalkeepers? There's very, very few articles in the literature about that. That's a Brazilian article by my colleague Beno Egisman. He published it on 12 goalkeepers, 80% of stability, but 20% of recurrence and feeling of instability was not acceptable for a goalkeeper. I remember once, a couple of years ago, I asked Dr. Castanha in Reading when we were together in a meeting, and he said that he will also, he will do a Bankera repair in a goalkeeper. Is that correct, Dr. Alex? So, see, you have different opinions, because in my practice in Brazil, if I see this player here, you're going to see that's a popular team in Brazil called Flamengo. His guy is 9 months after a Latarjet procedure. He's okay there, but let's see in front the movement he's going to do to catch this ball with his left shoulder. So I was pretty comfortable knowing that he has a Latarjet procedure, because I think that this kind of patient, if he keep on doing this for years, he failed already once a Bankera repair. So in my opinion, he will probably in this situation fail again. What I call about dead risk sports, there's also a guy, he's 1 year after the second, he's a bilateral Latarjet. He had multiple episodes. He does what I call a dead risk sports. I cannot imagine this guy dislocating his shoulder in this altitude, basically doing this. So if he dislocates his shoulder there, he is in danger. He's going to be panicking, and I believe that those guys has to be treated in a more aggressive way. Remember the first guy here? Okay. He got a Bankera repair, and actually he did very fine for the first 5 years. But he's a big surfer. This is Nazaré in Portugal. Those guys are crazy. They go in this big waves with like a really wall behind them, and he dislocated his shoulder. He was lucky because he has a brother who also does surfing, big wave surfing, and they had a strategy. Always one is in the jet ski and the other one is surfing. They never surf together. One is in the jet ski, and I know that for many times one has to rescue the other inside, because this guy dislocated his shoulder in a wave like that. This is not exactly that wave, but this is the surfer. And the brother once also had a fracture in his shoulder and an avulsion of his hamstring surfing. So the brother was there to rescue. And in this case, we didn't have to think too much. It was a failure, and we went to a Latarjet repair for him. The question is, everyone who does collision sport do a Latarjet, needs a Latarjet. I think that we have to differentiate between what is instability and what is labral tear, what is dislocation and labral tear. There's different too. You can have a labral tear without a dislocation. Normally, when we have a dislocation, we will have a labral tear. That's a glad lesion. That's for the people who call this Victor Belfort, was a Brazilian famous MMA athlete, and that was in 2009. We had a chance to repair. He has just a subtle instability. He couldn't put strength in his left shoulder to punch, and then we fixed his labrum, and that's 1 year later he went back and playing. So my strategy for sports is related now, in my experience, the literature says, and what we call the ASA criteria. Again, age, kind of sports, and the anatomy. Age, the younger, more prone to a recurrence. Sports, that risk and collision, a little more chance to failure. And anatomy, it depends on Hill-Sachs lesion, it depends on labral detachment, the type of labral detachment. I like to use also the glenoid tracking concept described by Itoi and Yamamoto. I don't make the numbers, but I always try to correlate what I see in the bone in the humeral head and what I see in the glenoid. So in my experience, you see here, overhead motion, I will probably do 80% of my case of Bankart, because I believe that the Bankart procedure is still a very good, reliable procedure when you have the good indication, as Dr. Tonini said. A good indication is good. 20%, I will go for Latarjet. If the patient has a contact sports, and maybe if it has high performance, he's an athlete, he plays for a professional soccer team or a professional volleyball team, I would probably still gonna do 60% of the Bankart and 40% of Latarjet. That's in my practice general statistic. If it goes to collision sport, which we don't have too much because we don't have in Brazil rugby and we don't have American football, but we still have some collision sports. Sometimes soccer can be a little bit overstrengthening. So I say that 20% Bankart and 80% of Latarjet. For the category of the dead risk, he had the first episode, probably half depending on how much he does, the anatomy and things like that. But if he has a recurrence, with a dead risk, I'll always go for a Latarjet, because I think that in this point, we have to think about the danger of doing sports like that. I talked to some people from Colombia, and then I include rafting, because there was an episode of someone who was rafting in Colombia. He fell, the canoe over him, he dislocated his shoulder, and he died. So this was added by a friend from Colombia. So I also put rafting like this. So that's my approach now. How much danger and more aggressive the sports, I tend to go to the Latarjet or a bone block procedure. I do myself it open. I understand that a lot of people are doing arthroscopically. It's not an easy procedure. It takes sometimes 3 hours, 4 hours, but the people who has experience had it decreasing this time. I just think that the learning curve is a little bit difficult for for the general population, including myself. So I would do probably a Latarjet. I also liked the approach for Marcus Scheibel, where he does an iliac graft procedure by scope. It makes the procedure a little bit easier than the Latarjet, so it's published in the literature, it's good to see. So that's my approach, remembering also that results can always trick you. This guy here was this is a true case, he's happy. He said, I don't need surgery because I have my shoulder. That's one case in Brazil, doesn't have to be, but results can trick you because satisfaction is very subjective. And in the end, although we publish a statistic, although we look for the better results, in the end what we like to see is the patient getting to you and said, hey, I'm happy. I came here to fix my shoulder, and I fixed my shoulder. And stability is a little bit different than cuff, because cuff repair is like, I come here because I want to play tennis, I don't want to have pain, I want to sleep well, and sometimes you don't have like a perfect result, but the patient is happy. He has some minor pain or some minor discomfort. But instability is different. The guy says, I'm coming here to fix my shoulder because I don't want my shoulder to get out of place anymore. And if it fails, he's not happy, because it's all or nothing. I always says that when we're home, and then the phone call and said, hey, Michael, you remember me? I fixed my shoulder that dislocated like 5 years ago, and then you're already a little bit, oh my God, here he comes. And there's like what I call the 50% chance of happiness or sadness. If he said, well, the shoulder that you fixed is perfect. The other one dislocated, say yes. But I said the opposite. Oh, you remember my shoulder? It dislocated again. And you keep like, yeah, I told you it can happen. It's not perfect, but it's very uncomfortable for us. Because even if you try to explain them that not recurrence is not always the cause, because you fix a shoulder, 10 years later, the guy fall from a motorcycle. I think that's a new first episode, but in the head of the patient is a recurrence. And also the second point of being unsatisfied is motion. Motion restriction. We know that losing a little bit of motion is not so bad, but if the shoulder is stiff, they are also very unhappy in this case. So satisfaction is individual, and that's what we look for when we treat our patients. Again, I would like to thank so much for being here. It's an honor to be in Egypt for the first time in my life.
Thanks, Professor Simoni. The next speaker, Professor Khalid Shohayeb from Cairo, is going to talk about, is arthroscopic Bankert repair still valid?
Thank you, Dr. Simoni. You made my talk easy. I'm going to talk about a hot topic now. Is arthroscopic Bankert still valid? Bankert lesion was described 100 years ago. Then came arthroscopy, elegant anchors, and we thought that we're attacking the pathology in a simple procedure, which is an arthroscopic Bankert repair. Everything in the beginning is in vogue. It was applied to all patients in the beginning, and then came the results, complications, and we found it's not the perfect surgery for all our patients when reviewing our short, medium, and long-term follow-up. We did it for subluxators, for first-time dislocators, for recurrent dislocation, Bankert, Alapsa lesions, bony Bankert, bone loss, irrespective of the percent of bone loss, Hill sacks, irrespective of the size and site, and we also attack the concomitant lesions in the same sitting. The shoulder has the widest range of movement, but on the expense of stability. But what is very strange that range and stability are still needed after surgery. What is more peculiar that the patient needs more stability after the surgery than the original stability with the same range. The usual question is, after arthroscopy, will it never dislocate again? I think the usual answer is no, it will dislocate with a similar injury as the first one. With different surgeries, possibilities vary, so we have to choose best surgery for each patient. What do we mean by failure? Failure, subluxation is a failure, dislocation, and even apprehension is a failure. Dissatisfaction, as we heard in the previous talk, is a failure. Inability to return to the same level of sports or work, a manual worker, or limitation is a failure. If we translate all of these into points and put them in the well-known scoring systems, then we'll have a low scoring system, which means a failure. We have to satisfy ordinary population, males, females, teens with dominant or non-dominant arms, manual workers, recreational sports, overhead athletes, and contact sports with our surgery. We all know the risk factors of arthroscopic Bankert repair, which are young age, male, number of dislocations prior to surgery, contact sports, large Hill sacks, glenoid defects, hyperlaxity, epilepsy, and addicts, and number of anchors. I mean by that your technique. There is continuous efforts to understand more the pathology of the Bankert and associated lesions in an attempt to improve our results. Beginning from Tibia and Burkhardt 20 years ago, and Ito and Giacomo tried to put us on track concerning bone loss, and Wolf eliminating this humeral bone loss with his technique. We're going to talk about it later. Now, going back to the risk factors, we attack the bone loss, but young age means young age. When you have your dislocation at 18, then you're 18, you can't say that you're 25. Male, you're a male, and you can't change your sex. Number of dislocation prior to surgery needs patient awareness to get his surgery as early as possible. And contact sports, usually players like to continue on their sports. Hyperlaxity is hyperlaxity. We can't do anything for it. And there is no surgery that can beat epilepsy, convulsions, or fits. Even lethargy or bone blocks don't beat the epilepsy. And in our country, we have a problem with addicts, tramadol addicts with convulsions. Overdose, they get convulsions, anterior, posterior, fracture dislocations, and it's a big problem in our country, actually. You can usually improve your technique and keep getting your technique better. Pascal Boileau, 13 or 14 years ago, he introduced his ISIS score, the Instability Severity Index score, and he stated that it's a simple way to know whether we're going to do a Bankert or a letter J for these patients. He gave age 2 points, contact scores 1 point, competitive scores 2 points, shoulder hyperlaxity 1, loss of glenoid contour on the AP and not on the CT, and on the AP X-ray 2 points, and heel sacs visible on external rotation, again on an X-ray and not on a CT. And he stated that 6 points or less are acceptable recurrence rate of 10%, and more than 6, an unacceptable recurrence rate as high as 70%. That was revised several times. And the French Arthroscopy Society 3 years ago, I know that the French are leading the world in the shoulder. In a multi-center study from 11 centers from the most well-recognized shoulder surgeon all over France. In a prospective study, they found that 4 points or less of ISO score gave about 20% failure rate at 9 years follow-up, provided there is no bone loss, either glenoid or humeral, and the main predictive factor for recurrence remained age under 20 years. After revising the ISO score, the cutoff points are 2 now, at least using 3 or 4 anchors and excluding first-time dislocators and bone loss. First-time dislocators because they have better results, and bone loss, as we know, have worse results. I remember somebody was asking Pascal Boileau 3 or 4 years ago, this means that we'll never do a Bankert repair. Again, he said, yes, we'll never do a Bankert, arthroscopic Bankert repair. Have a look again at the ISO score. I think it's very important to apply it for our patients. If you go back to the literature, a very important paper by Christian Gerber and his group from Zurich, and this is a long-term results for 271 patients with arthroscopic Bankert repair with a very high unacceptable result of 40% failure. I think this is a very, very high failure rate, and in contrast to 93 letter J with an 11% failure, also this is somewhat high. If we go to the literature, ranges are from 20 to 30 to 9 to 10, and Castagna is here. I remember, and we heard him crying about his arthroscopic Bankert repair results 10 years ago in the early morning in the first session of knee shoulder course, and I personally was dissatisfied with that by that time. And other ranges also between 20 to 30% of failure. An important paper by J.P. Warner and his colleagues from Boston, and the Alapsa lesion has worse results other than the Bankert lesions. And for first-time shoulder dislocations, we have better results for the first-time dislocators with a failure rate of about 7%, and other papers, other authors say it's the same. Glenoid bone loss, my colleagues are going to talk about it in later sessions, but it began with Burkhardt and De Beer with the engaging and non-engaging heel sacs, and then came also Burkhardt and Giacomo and Itoi once more with the on-track, off-track concept, and here is how to calculate the bone loss of the glenoid. It's a simple procedure, but I leave it for my colleagues. For a long time, and classic teaching was saying that 25-30% of glenoid bone loss is acceptable to do your arthroscopic Bankert repair. I believe this is not acceptable at all. There's no meaning that you have lost your 1/4 or about 1/3 of your glenoid, and then you expect a good result with your arthroscopic Bankert repair. Now it's about 13%. I think with time it will be 0% bone loss of the glenoid, because every millimeter of bone, I think, is very important, the stability of your shoulder. Heel sacs again, I think one of my colleagues were going to talk about it. The exact size, there's no consensus about how much, but here in the lower right, how to calculate it on the on-track, off-track, and I think we have to respect it. Eugene Wolf presented his technique of remplissage as an arthroscopic solution for engaging heel sacs, and it was a new arthroscopic technique for an old open French surgery for remplissage dating back to 1972. And the results after remplissage with a Bankert repair give better results about 11%, and in other papers it's about also 20%. When going on track or off track, according to Tokash, when performing banker repair on track, you have a failure rate of about 20%, also the same rate as usual, and then off track you have a failure rate of about 75%. What did we learn from the on track, off track of the Giacomo and Itoi? It told us what to do. If we've got less than 25, going to do a banker, to the remplissage, or we'll omit completely banker and do a lethargy or a lethargy and a remplissage. Then, what after this, all of this dilemma, what to do? Everything is in vogue in the beginning. All cases we performed bankert, elapsa, inferior capsular shift, TOTS technique of Pascal Boileau, first-time dislocators. We made an anatomical repair. ISIS revised several times. Glenoid bone loss from 20 to 30% to 13%. Hill sac from nothing to be done to the Hill sacs to engaging, non-engaging, bipolar, on track, off track, and remplissage, and ISIS score modified several times. And then comes the lethargy to be the main or the gold standard for shoulder stability, and stood the test of time with a failure rate from 5 to 11% and the highest rehabilitation rate. So what to do? Proper history, clinical examination, full investigation, ISIS score to be applied, and you have to tailor your surgery according to the needs of the patient. And banker is still valid with limits. And I think this view is very important. It's mandatory now to have this view in all our recurrent cases because it tells us a lot of the bone loss. Thank you very much. This is our famous Cairo University, and this is our Asr Al-Aini School of Medicine of Cairo University. We serve 6,000 beds, 6,000 beds in our hospital. Thank you very much.
Thanks, Professor Shohayeb. The next speaker, Professor Waled Reda, Cairo University, is going to talk about bony bankers.
Thank you for the invitation. Good morning. Today I am a continuation of the previous talks. I will talk about the bony bankert, which is something the more you look, the more you will find. The incidence of anterior glenoid rim fracture, which is a bony bankert, vary greatly in the literature. It varies from 4 to 70%, and there is a prevalence, high prevalence in males. The shoulder stability in the past. When I was young in my beginning of the practice, every recurrent shoulder dislocation equal arthroscopic bankert repair. And my professor, who is my professor also, it is a capsular shift and shortening of the subscapularis. But in the past, so it was all focused on soft tissue envelope of the shoulder without taking any consideration of the bone. But in the last 10 to 15 years, more attention was paid to the bone, especially the glenoid, studying its role in the stability. Normally in a healthy shoulder, the transitional forces doesn't exceed the compression force, so holding the head in the socket or the glenoid. But when we have an anterior glenoid defect, the situation dramatically changes, and so we have to do something with this defect. We have to reconstruct it. Also, bony deficiency of the anterior glenoid rim has a higher failure rate after arthroscopic only soft tissue management. The classification of glenoid rim fracture or the bony bankert is described by Bigliani many time ago. Its type 1 is a Belgian fracture of the attached capsule. The type 2 is a medial displaced fragment, either attached or not attached to the capsule. Type 3 is erosion of the anterior glenoid, which is further divided in type 3A with less than 25% deficiency, and type 3B more than 25 bony deficiency. To assess the glenoid rim fracture, we have to start with a standard X-ray radiological assessment, a true anteroposterior internal rotation, external rotation view to view the heel sacs, and a Bernagau view, which shows the glenoid deficiency well. And when we have bone loss, when there is bone loss is suspected, either CT or MRI should be considered to accurately quantify the bone loss. 3D CT, that Dr. Khalid said, it is mandatory in every assessment. We do the en-face view, and we assess the glenoid rim deficiency by two ways that we will see in the next slide. But first, we do the best circle, as we see here in the right side. These are two methods to quantify the amount of glenoid bone loss, either linear measurement with the glenoid index measure, or the PICO method to quantify the bone loss surface area. Also, we can calculate the amount of glenoid bone loss arthroscopically using the Burr spot, and this method also helps you to assess the posterior and superior defect of the head, the heel sacs, and also we can do dynamic examination of the shoulder to see if it is engaging or not engaging. There is still no consensus on the critical amount of glenoid bone loss above which we need to do reconstruction. Itoy and al. Found osseous defects with more than 21% of the glenoid length lead to significant decrease in the stability. Yamamoto et al., it is equal or greater to 20%. Gerber found another equation which measures the length of the glenoid bone deficiency and compare it to the radius of the glenoid. And if the length of the glenoid bone deficiency equal or more than the radius of the glenoid, this is unstable shoulder, and grease if it is 20% of the diameter. So it is a little bit variable, and the most recent studies that I found discussing the critical value in 2017, it proposes that 17.5% loss is the critical value above which bone reconstruction is recommended. Also, they proposed the concept of subcritical bone loss to be reduced from 17.5 to 13.5 in high demand athletes. But the glenoid bone loss is not the only factor determining glenohumeral instability. The humeral bone loss also is important. The study by Giacomo, which had changed the concept of engaging and non-engaging to on-track and off-track. This is how the glenoid track is measured. This equation, it is 0.83 time d, it's the diameter of the glenoid minus the glenoid defect, and this is where we assess the glenoid track. And the heel sacs is not only the heel sacs which is important, it is the heel sacs index. We add the heel sac plus the interval between the defect and the rotator insertion, and this is the heel sacs index. If the heel sacs index is greater than the glenoid track, this shoulder is off track and need to do a glenoid reconstruction. There is also other factor very important in the decision making: the age of the patient, the number of previous dislocation, the level of sport, the presence of hyperlaxity, and reconstruction even with small lesion and even with on-track shoulder can be considered if the patient is young. The Instability Severity Index score proposed in 2006 tried to solve this problem. The score depends on 5 items: the age of the patient, the type of sport, the degree of sports activity, the hyperlaxity, and the heel sags and the glenoid deficiency. Each item takes 2 points except the hyperlaxity and type of sport, which takes 1 point only. If the ICE score is more than 6, so a bony reconstruction for the glenoid is recommended, but I think this score needs to be revised at least for the value of each item. It is unfair to have the glenoid deficiency like the degree of sports. So the management objective for us is on short term, we want to have a stable shoulder and the patient return to sport as soon as possible. And our long-term management objective is to remain this stability and no arthritis development. So when the lesion is small and the shoulder is on track, an arthroscopic bony Bankert can be performed. Many techniques are available: single row, double row, the Sugai technique, and also a remplissage can be added if there is a large heel sacs. But when there is a significant glenoid deficiency and an off-track shoulder, a glenoid reconstruction is always recommended. This can be done either by an iliacrest graft, like the Eden-Hibinet procedure, or the J-graft, or with a coracoid transfer, which is the letter J procedure. The Eden-Hibinet procedure can be done either open or arthroscopic, and I think in the starting of the learning curve, it's much easier to start with an arthroscopic iliacrest graft rather than to start with an arthroscopic letter J, which is more difficult arthroscopically. The letter J procedure is an anatomical repair technique used in which the coracoid process and its conjoined tendon is transferred to the anterior glenoid. Latarjet procedure was first described in 1954 by Michel Latarjet, but this procedure didn't take its reputation until surgical techniques has been modified and described by Dr. Gilles Valch and Dr. Didier Pat, who analyzed its principles, which are, number one, the bony reconstruction of the anterior glenoid, which increases the glenoid arc. Number two, the sling effect by lowering the inferior fiber of the subscapularis, having a check rein against anterior-inferior translation of the humeral head in the abduction and the external rotation. And lastly, a capsular effect by suturing the coracoacromial ligaments and we take with the coracoid process to the anterior capsule, reinforcing it. When we are reviewing the literature, we found there is a superiority of bony reconstruction over bony Bankert repair. And these are some examples. This is a study published in the Casta journal comparing the bony Bankert repair and the glenoid reconstruction is patient with glenoid deficiency, more than 20%, 24 patients underwent bone graft, and 22 patients underwent bony Bankert. The raw score and the return to sport and recurrence rate was assessed. They found significant superiority of the glenoid reconstruction group over the arthroscopic bony Bankert, especially in the redislocation rate. Another systematic review with a minimum of 5 years follow-up in the Journal of Sports Medicine on 1,652 patients repair, minimum 5-year follow-up, recurrence rate, also raw score, arthritis complication, and they found the redislocation rate in the Bankert is much higher than the Latarjet group. Another study on the borderline glenoid defect from 15 to 20%. It was a retrospective study between Latarjet and Bankert repair, and also they found that both groups had satisfactory outcome. However, the Latarjet group has significant less recurrence rate and significant less external rotation deficient. When comparing the Latarjet with the iliac crest graft, we found that most studies found no significant difference between the two groups in terms of clinical and radiological outcome, only donor side disturbance in the iliac crest graft group. Another study comparing both groups and found no significant difference between Latarjet and iliac crest graft in terms of strength and stability. Only result from CT showed that glenoid augmentation effect was seen in patients underwent iliac crest graft. Then glenoid more, we can do more reconstruction with iliac crest graft. However, this decreased over time in the follow-up. This is the whole flow. Another systematic review performed this year on iliac crest graft and proved it is safe and effective in short-term treatment of substantial glenoid bone loss. Another one in this year also, in the Journal of Joint and Bone Surgery, a randomized controlled trial in 2 centers, one is the USA and one is Germany, on 60 patients with more than 20% glenoid bone loss and an average follow-up of 24 months. They found no significant difference at 6, 12, and 24 months of follow-up. Lastly, thanks to iliac crest graft, because it can be the salvage and revision procedure when all other techniques fails. There is other two way of reconstruction of the glenoid which are not as popular as the Latarjet and the iliac crest graft. The first one is the distal tibial allograft, where we take the lateral part of the distal tibia and harvest it and fix it to the anterior glenoid. And this study performed by Anthony Romeo on 27 patients with more than 15% glenoid bone loss and find excellent clinical outcome and minimal graft resorption. The second alternative is the distal clavicle autograft, though it is not popular also, but it has several advantages. First, it can restore significant greater defect. It has a broader radius than the coracoid. It is locally available and minimal donor side morbidity, and it provides also articular cartilage to the graft. So my home message is, any glenoid bone deficiency has to be reconstructed. Thank you.
Thanks for all the speakers. We open the floor for discussion. We're quite sure we have a lot of questions, but only we have 10 minutes. Mohammed.
My question to the first speaker, Dr. Tonino, about the anterior labral in athletes. In your conclusion, you said that in high contact athlete with labral tear, you prefer conservative treatment over the surgical procedure. Am I right?
So you can have an instance where in a high contact athlete, they dislocate their shoulder during the season. If they have surgery, I'd like to do surgery because they need surgery. But in the middle of the season, or if it's towards the end of the season, they want to keep on playing, you can try the brace to see if you can rehab them and prevent their shoulder from being abducting and externally rotating. Some football players, all they need to do is this type of movement. They don't do this kind of movement. So with the brace, they can continue playing in a contact sport until the end of the season, or sometimes in basketball or other sport, just to get them through the end of the season. Then when the season is over, then surgery. It's not a long-term treatment.
But they explain to them that they are playing with risk.
Of course, yes.
So you take the risk with them.
Yes, they are grown people, intelligent people. You will discuss the risk with them. If they say, no, I don't want to accept that risk, then we do surgery. But many times these are very important athletes. So I'm saying this is one thing you can do for a high-level athlete who is a very important player. This is an acceptable type of treatment during the season to get them until the end of the season, but it is not a long-term treatment
But
for
at
the
the end
patient.
of the season, you repair the tear,
Sure.
or you re-evaluate it again. For checking
Most
for-
of the time, I'm operating on them. That's my deal. We'll try and get you until the end of the season, but then you need surgery after the season's over.
Okay.
Make me a comment very fast. I was a team physician for more than 10 years in Brazil, and it's barely impossible to take someone in the middle of the season and say, no, we're going to stop the season now and you're going to do surgery. Although they are very unstable, the athlete himself, they want to go not on surgery. So they want to put a brace, they want a strength, but they're not going to go on surgery during the season. In the end of the season, okay, if you plan, it's okay, but many of them say, doctor, I'm feeling well, I don't want to go on surgery. And some soccer players in Brazil go to the end of their career without repairing the labrum. So it's variable.
I think it's important. They say they feel better, but I examine them. So if they say I feel better, but I examine them and they have an apprehension test, then they need surgery. I don't care how they feel.
Peeping out, and still some of the graft is there. What you will do? Removal of screw or just wait and see?
If it's causing pain,
Yeah.
we'll remove the screw. But usually with this resorption of the upper part of the graft, the shoulder is stable and we have nothing to do with it. But if there is pain, you have to get the screw out.
I think this is the whole flow. The proximal part of the graft always takes the shape of the normal glenoid. It depends on the force on it. But we saw it when follow up after 3 to 4 years. If it is not painful because the screw is extra articular, it will not do any problem. If it is not painful and doing nothing to the patient, no complaint, I think there is no reason to remove it.
Dr. Bassem, تفضل.
Thank you for these very nice presentations. Especially I want to thank Dr. Shohayeb for his very nice presentation explaining the pathology and the causes of the instability and dislocation very details. And he mentioned also the inferior capsular shift. I just want to remind you, in the past, when it was open surgery, Carter Rowe started doing Bankart repair alone, and then he shifted to do Bankart repair with capsular shift. Then came Neer, Charles Neer, who trained me, and he said we have to correct the anatomy, and that is the most important target to do. So if you have a Bankart lesion, we repair it. If you have a capsular redundancy on instability, he repaired it with doing an inferior capsular
It's
shift.
part of our surgery. If we got
I'm not
no?
finished, excuse me.
Yes.
So the problem now is that I see here problems of doing only Bankart and say no Bankart and so on, and then shift to lateral GA to deal with this problem. But the problem is actually the capsule, the ligaments. The ligaments are redundant, and they are the most reason for stability. So no address was done except with you. You mentioned the shift. So correcting of the anatomy, I think, is the most important thing. Doing the Bankart and also doing the dealing with the capsule, either with any procedure or an arthroscopic or open inferior capsule shift. Thank you.
Yes, it's part of our surgery. If we've got a recurrent dislocation of 4, 5, 6 times, there's always redundancy of the capsule. And with the Bankart repair, an inferior capsular shift is performed with the anchors in the same setting. And the first anchor is crucial in doing that. And then the 2 other anchors or 3 other anchors are just for maintenance of the position. The first anchor is the most crucial in having a shift on it. From below upwards or from south to north as taught.
دكتور عزت اتفضل.
For me, I use both. Sometimes I do a mattress, sometimes I do a simple suture. I don't think there's a great difference in the technique or the results of either technique.
Concerning the letter J procedure, there was a debate whether to keep the graft extracapsular or you repair it to the CA ligament intra-articular, I mean, to decrease the risk in long-term arthritis. Do you do this, or you found it irrelevant?
Sir, I didn't understand your question. Do you think you do?
There was a study that they put anchors in the anterior glenoid to suture the capsule of the lateral capsule to those anchors, keeping the graft or the part of the bone extracapsular.
Yes.
So not for the head to have a friction with the bone, to keep it all the time with the articular cartilage.
Yes, I understand.
Is this relevant or not relevant in the long-term arthritis?
This is one of the advantage of doing an arthroscopic letter J. It is the technique of Pascal Boileau that he do Bankart repair plus coracoid transfer and keeping the graft, all the graft extra articular. But the standard letter J's that open letter J's that we do is that we put the graft and we don't do Bankart repair. Only we can suture the coracoacromial ligament to the capsule. Okay, and this is as a capsular effect adding. I don't think there is a big difference. I don't think also there is a lot of studying the difference in arthritis in the long term between two procedure. But the most important factor is the position of the graft you are putting, that is not proud on the edge or even a little bit medial to the edge of the glenoid. And this is the main factor that predict if there will be an arthritis developing or not.
For me, sometimes I do the capsular repair with anchors after doing the lateral J, but in an external rotation position we're tightening the capsule. But what I found out, what I find always is that rehabilitation is slower in this technique than an ordinary lateral J. Loss of external rotation persists for some time, in contrast to the lateral J that gains about full range in 1 month or so.
Did you define some bone loss in glenoid, or you decide according to something else? Primary to do iliac graft.
Primary if we have a coracoid fracture.
All right, I'll answer this. We've got a problem here in our country with tramadol addicts, as I said, and they have overdose of tramadol, they have convulsions, and with convulsions, a lot of them have coracoid fractures. You're faced with a very small coracoid, it's displaced with the tendons, and then you have to do an initial iliac bone graft. I think this is the only indication. Otherwise, you have to do a lateral J if you've got a normal coracoid. So this view that I viewed is very important, because to see also if the coracoid is intact or not. We're faced a lot with this in tramadol addicts and convulsions.
Thanks for all the distinguished speakers for this excellent session, and the next for coffee break.